Um, I have the pleasure to be here for another time participating in this radiosonography course sponsored by AstraZeneca, and the course is composed of 4 parts, and this is the fourth one and the last one. The first was about the imaging of the chest, the second one was about the imaging of the abdomen, the third one was about the brain and the cerebrovascular stroke, and this last session will be about imaging of the urinary system. All the lectures are recorded and given to the company. They will print the CDs and deliver it to you, inshallah. Then starting evaluation of the urinary system, I have to say that we have a lot of imaging modalities in this particular domain, including the essential one, which is the plain X-ray of the urinary tract, known as plain UT or KUB, kidney ureter bladder, and the famous examination, which is intravenous urography. Then we have the cystography and the urethrography, and ultrasound, nuclear medicine, CT, MRI, and some of the interventional techniques. And to start with, I will show to you some of the values of each of these imaging modalities. Then we'll discuss how can we approach the urinary tract by using these facilities. Then the plain UT is the simplest one, and it usually requires some patient preparation in order to decrease the amount of food residue in the intestine and to improve the gas shadows within the abdomen. This plain UT is very valuable in diagnosis of radiopaque calculi, detection of calcium in the kidney or in the urinary bladder, also show the gas pattern within the abdomen, and they can also assess if there is an organ enlargement, and finally to detect any bony abnormalities in the skeleton. Then this is one of the values of this plain UT, which is the detection of calcium, and this is one of the famous forms of calcium in the urinary tract affecting the urinary bladder, which is usually indicative of bilharziosis of the urinary system. Then the intravenous urography requires injection of contrast media. Then the patient should fast for about 4 to 6 hours, and then we ensure adequate bowel preparation similar to the plain UT, and we also should ensure a good renal function before injecting this contrast material. Then we have 2 types of contrast media, the ionic one and the non-ionic one. This ionic one has a relative frequency of inducing some reactions if it is injected in the human body, while this non-ionic one is less harmful either to the kidney and also in inducing allergic reaction. But of course the price is different. This is a more cheap contrast material, and this is a relatively expensive one. Then if we inject the contrast material and this material will be excreted by the kidney, then we can see the pelvic ileal system, we can see the ureter, and we can see the urinary bladder. This IVB is very valuable in detection of or assessment of the renal function, detection of urinary tract obstruction and the level, also assessment of renal and urinary bladder masses, and finally the detection of congenital anomalies. Then 2 main obstacles against this technique is renal impairment, and we cannot inject contrast material. Then the second one is major hypersensitivity to contrast media, and this is also an obstacle. This is the series of intravenous urography. We start first by the plain UT, then we inject the contrast material, then we have a film after 10 minutes and another film after 20 minutes. And in both films we can assess the collecting system, we can also see the ureters, and we can see the urinary bladder. Finally, we should have a spot film for the urinary bladder before evacuation and after evacuation. And the value of the plain film before injecting contrast material is shown here. This is the plain film where a very big stone is seen in the left renal area. After injection of contrast material, you cannot see the stone because the stone is dense and the contrast media is dense, so the stone will be masked by the contrast material. Ascending cystourethropy means that we introduce a catheter in the tip of the urethra, injecting contrast material to show the different urethral segments. Then continuing injection, we can also opacify the urinary bladder. This examination is known as ascending cystourethropy, and then we allow the patient to micturate, and we have films known as micturating cystourethrogram. Then ultrasound is one of the valuable methods for assessment of the kidney and urinary bladder. The examination of the ultrasound is relatively non-invasive. It is very reliable and less expensive compared to other imaging techniques. Then ultrasound requires some fasting, and it may not require some bowel preparation, and it does not require the injection of contrast media, and of course there are no radiation hazards. Ultrasound is valuable in detection of the renal parenchymal changes. This is the normal echogenicity of the renal parenchyma. Detection of renal calculi, and this is a big stone in the pelvic ileal system with characteristic posterior acoustic shadowing. Also in detection of urinary tract obstruction, differentiation between cystic and solid masses, and assessment of congenital anomalies. Then the CT scan usually requires the injection of contrast media. It is relatively more invasive compared to ultrasound, and the injection of contrast media may initiate some of the reactions, as I have said. And CT is valuable in detection of urinary tract calculi, detection of the level and the cause of obstruction, differentiation between cystic and solid masses, and in assessment of congenital anomalies, as well as in the detection of the renovascular abnormalities. And these are the series of CT scan obtained after injection of contrast media. You can see contrast material in the aorta, and this is the left kidney and this is the right kidney. We start from the upper pole, then we proceed inferiorly until we can finish the whole area of the renal parenchyma. And by this examination, we can assess the size and the site of, and the shape of the kidney. We can see if there is hydronephrotic changes or not. We can also detect renal masses, as I will show to you. And these are the images through the kidneys, and this is the lower renal ball on both sides. Then this is one of the most important techniques nowadays performed in the clinical practice for detection of urinary tract calculi. And this technique is known as CT-UT, or CT of the urinary tract, without injection of contrast media. We scan the area starting from the upper pole of the kidney down to the urinary bladder every 3 millimeter slice interval. And this area is covered in order to show any radio-opaque calculi in the region of the kidney. Then we finish the kidney and we go through the region of the ureters. Then we continue until we reach the level of the urinary bladder and finish the scan by termination of the level of the urinary bladder. Then if you look here in this particular image, you can see a radio-dense shadow on the right side of the pelvis. This shadow may represent a stone, and it may also represent a phlebolus, which is frequently seen in the pelvis. Then we should have these images, and these images are very valuable, obtained by CT, reconstructing the previous images into longitudinal one. Then you reconstruct the image along the ureteric course, then you can see the ureter along its whole length down to the renal bladder. This is the left ureter, and here you can see the right ureter. And you know that there are no radio-opaque calculi along the course of the ureter. Then you know that this particular radio-opaque shadow represents just a phlebolus. And whenever you ask for this examination, which is CT-UT, you should ensure that you have these reconstructed images because they are extremely valuable in the diagnosis. Then if you inject the contrast material, and you can use the CT scan to perform this image, which is known as CTU, which is the abbreviation of CT urography. By CT, you can remove all undesired structures. You can remove the liver, the spleen, the intestine, and so then you are left only by the kidneys. And you can see the left kidney, the right kidney, the pelvic ileal system, the course of the ureter, and the urinary bladder. And many of the machines can produce these color images, which are of no significance in diagnosis, but they usually give better imaging of the urinary system. But here, these images are valuable in the diagnosis. These are not. In the previous days, in order to see the renal vessels, we used to introduce a catheter through the femoral artery into the aorta. Then we inject the contrast material. Then the contrast will opacify the left renal artery and the right renal artery. This technique was known as the flush aortography. But nowadays, after the introduction of multi-detector CT, you can have this examination, which is known as CTA or CT angiography. You just inject contrast material intravenously. Then you ask the machine to scan the renal vessels whenever the contrast reaches the renal vessels. They are programmed for this. Then you can have this image. This is the aorta, and this is the celiac branch, and you see the renal vessels in a case of horseshoe kidney. Then you have the chance to remove the undesired vessels and the structures, and you are left with the horseshoe kidney, which is supplied by 3 branches on the left side and a single branch on the right side. You can also have the color images using the same CT machine, showing the horseshoe kidney and the feeding, the supplying vessels. And if you are not interested in the spine and the ribs, you can remove all these structures, and you are left only with the renal vessels and the horseshoe kidney. And MRI is one of the important imaging techniques, but it is not usually used frequently in imaging of the urinary system unless we have the two main obstacles of contrast injection. If you are not able to inject the patient with contrast material because of the bad renal function or the marked hypersensitivity to contrast media, then you may revert to MR. MR does not require to inject the contrast material in order to obtain these images, which are very clear about the left kidney, the right kidney, the renal vein, IVC, and the aorta. And also you can obtain this image without injecting the patient with contrast material. This is known as MRU or MR urography. No contrast is needed. We use only the flow of urine in the urinary system to initiate this image. No contrast material is required. Then you can see the pelvic ileal system, the ureter, and the urinary bladder. And also this is an examination which is known as MR angiography or MRA, and also once again there is no need to inject the contrast material. You use the flow of the blood in the vessels to obtain these images. Then if you are not able to inject the patient of contrast material because of the bad renal function or hypersensitivity, you can assess the vascularity and you can assess the pelvic ileal system by MRI without the need to inject contrast material. Then we came to the pathology that we can usually see in the urinary system. This includes the most frequent disease, which is the obstructive uropathy due to calculi. Then we'll talk about some of the neoplasms in the urinary system, UTI infection and urinary tract trauma, and some of the miscellaneous lesions, including the congenital anomalies, vesico-ureteric reflux, urethral pathology, and finally the renovascular hypertension. And starting first by the the stone disease, we have the radiopaque calculi and the radiolucent calculi. Radiopaque calculi will appear in the plain film as dense shadows. This is a small radiopaque calculus in the left kidney, and this is a larger, what we call a staghorn calculus in the left kidney also in another patient. Then you see a lot of radiopaque calculi in the region of the urinary bladder. These are the radiopaque calculi. But if the stone is radiolucent, you can see it after injection of contrast media. Here you can see a triangular shaped stone in the renal pelvis, another one in the lower ball minor calyx, as a filling defect in the collecting system compared to the normal collecting system on the right side. Then look at this patient, and this is a normal urography, kidneys, ureters, and urinary bladder. In this particular case, you can see the left kidney is functioning good, and this is the collecting system, and this is the ureter. But on the right side, there is some delay in the function, and the shadow of the kidney is here, but this arrow points to a suspected radio-opaque calculus in the distal part of the ureter. The delayed fill confirmed this possibility. Here you can see that the pelvic ileal system is distended and the ureter is dilated along its whole course, secondary to obstruction of the ureter by this very small calculus. Then ultrasound can also detect ureteric calculi, but if they are large. And you see this is hydronephrosis, the calyces and the renal pelvis are dilated. This is the upper part of the ureter which is dilated, and the rest of the ureter is dilated down to this stone in the terminal part of the ureter. In this plane film, you can see a radio-opaque shadow here. And this radio-opaque shadow may represent a stone or may represent a phlebolus. Then in the previous days, we used to inject the contrast material. Then in IVB, you can see normal appearance of the right kidney, but the left pelvic ileal system is somewhat distended. The ureter is also distended down to the obstructive lesion, which is the calculus in the terminal part of the ureter, present here, and this is the normal ureter distal to the calculus itself. Then if you see an intravenous urogram like this one, the right kidney is good, the left kidney is distended, and the ureter is also dilated along its whole course. Then two possibilities, either a stone in the terminal part of the ureter or a stricture in this vesico-ureteric junction. Then we may have the CT scan and we can see the stone at the vesico-ureteric junction. The reconstructed image can show the ureter along its whole course and the stone in its terminal portion. And these are two different examples by CT-UT showing ureteric stones. This is a stone in the distal part of the ureter with proximal back pressure effect, and this is a stone in the upper part of the right ureter with distension of the renal pelvis proximal to it. And in this CT scan, you can see the left kidney is good, but the right kidney is enlarged and the renal pelvis is distended. Then going down into the pelvis, you can see the cause, which is a small ureter, a small ureteric stone near the vesico-ureteric junction. Then this is the CT-UT done before without contrast injection, showing multiple bilateral renal calculi. And lower down, you can see also the stone in the right kidney and some calculi in the left kidney. And you can see also this calculus, which is possibly present in the upper part of the ureter. Then you should obtain these reconstructed images. And here you can see multiple calculi in the pelvic ileal system and a stone in the upper part of the ureter with distension and dilatation of the pelvic ileal system. And this arrow points to a small radio-opaque shadow on the right side of the pelvis. This may represent a phlebolus and may represent a stone. And this is a CT urography obtained after injection of contrast material, showing a duplex left kidney with normal ureter, and the right kidney is the pelvic ileal system is dilated, and the ureter also, and this arrow points to the site of the stone, which is located in the distal third of the ureter. Then coming to the urinary tract neoplasms, and we have benign masses and the malignant masses. If we look to the IVB, we can easily differentiate between benign and malignant lesions. Benign lesions usually displace and stretch the calyces, while malignant lesions usually destroy and erode the calyces. And this is a very good example of a benign lesion in the left kidney stretching the upper ball major calyces. And the CT scan of the same patient showed that this is a simple renal cyst. Then in order to discriminate between benign, like the simple renal cyst, and malignant, like renal cell carcinoma, we may obtain ultrasound. And this is the normal kidney. This is the appearance of the normal kidney. And this is the appearance of a cyst. And this is the appearance of a tumor. The cyst contains a fluid, but the tumor is solid, as you can see. and this is also can be obtained by CT. This is the difference between simple renal cyst, which is filled by clear water density, and the renal cell carcinoma, which is a solid lesion. And you know that the most common by far solid renal tumor is the renal cell carcinoma in adults. And this is a classic appearance of a simple renal cyst by ultrasound. This is the kidney, and this is the simple renal cyst showing fluid echogenicity. Then by CT, you can see this is the right kidney, and this is a simple renal cyst. And if you reconstruct the image, you can see that this cyst is arising from the renal lower ball, and the renal function is preserved, and the ureter is also okay, and the left kidney is good. Then whenever you see multiple cysts in the kidneys, bilateral, and also in the liver, then you are dealing with polycystic disease. And this polycystic disease can be diagnosed if you can see multiple cystic lesions in the liver as well as in both kidneys, and sometimes you see in the pancreas as well. But if you see a solid mass in the kidney, you are in the diagnosis of renal cell carcinoma. And you can see this is the left kidney, and there is a big mass arising from the lower ball of the kidney. These hypodensities within the tumor mass represents tumor necrosis, but still you can see viable tumor tissue or allowed. And if you diagnose renal cell carcinoma, we have to say something about renal vein invasion, IVC invasion, perinephric extension, lymph node enlargement, and metastatic deposits. And this is an example of renal cell carcinoma by ultrasound and CT. This is the mass arising from the kidney, and by CT you can see that this is the mass. B refers to the normal renal parenchyma, T refers to the tumor tissue, and N refers to the necrotic part of the tumor. And another case of a big renal mass on the left side representing renal cell carcinoma, and the mass is invading the renal vein, as you can see. This is a very important information for management. But if you see a solid mass in the kidney of a child, then you are in the diagnosis of nephroblastoma or Werner's tumor, which is the most common by far solid mass arising from the kidney in the pediatric age group. But if you see a mass within the collecting system like this, and this is the renal pelvis where you can see a big filling defect inside the pelvis, or this is the CT scan and you can see a soft tissue mass within the renal pelvis, then you know that this is urothelial tumor, which represents the transitional cell carcinoma. And transitional cell carcinoma can occur also in the renal bladder, and they can occur multifocal in the collecting system, in the ureter, as well as inside the renal bladder. And the most common mass inside the renal bladder by far is the transitional cell carcinoma. And here you can see this is the normal bladder, and this is the bladder containing a soft tissue filling defect representing the tumor, which is transitional cell carcinoma. Another case by IVB, you can see a mass inside the renal bladder causing filling defect, and by CT you can see the mass inside the renal bladder, and this is the urine contrast fluid level. Another case of urinary bladder cancer or transitional cell carcinoma as appearing as a filling defect or a mass inside the urinary bladder. And another case also, and you can see here in the left side of the renal bladder a mass. And of course you know that the tumor mass is not mobile because it is attached to the bladder wall, while the calculi or blood clots, for example, will move inside the renal bladder. Then you can confirm the diagnosis by using ultrasound, and here you can see the soft tissue mass which is adherent to the wall of the urinary bladder, representing transitional cell carcinoma of the renal bladder. And here another example of carcinoma of the renal bladder affecting the right side of the wall of the renal bladder. And whenever we diagnose this, we have to mention something about extravesical extension and the invasion of the perivesical fat, of course the enlargement of the lymph nodes and the metastatic deposits. Then we came to the renal trauma, and whenever you are confronted by a case of blunt abdominal trauma with suspected injuries in the urinary tract, the best way for assessment is contrast enhanced CT scan. And by contrast enhanced CT scan, you can see one of three things. Number one, perinephric hematoma, this is the kidney, and the soft tissue mass posterior to the kidney in a case of blunt abdominal trauma is diagnostic of perinephric hematoma. Or you may see renal laceration, and you can see that the kidney is fractured into pieces with a huge perinephric hematoma as well. And this is another example of a child who received the direct trauma to the left side or to the left loin and presented by immediate hematuria. The non-contrast CT scan showed that the left kidney is enlarged. After injection of contrast, you can see a big hematoma with some enhancing lacerated renal parenchyma. Then you can use the CT scan to reconstruct the image, and you can see that the lower ball is avulsed from the rest of the kidney, and surrounding the kidney a big hematoma corresponding to the bleeding here. And you may also obtain these images in color, and you can see this is the affected kidney with a avulsed lower ball of the kidney. But if you look to a traumatized patient, and you can notice this finding, the left kidney is excreting contrast well, but the right kidney does not excrete contrast. Then you know that contrast material is not able to go into the kidney. Then you know that the vascular pedicle has been avulsed. And whenever you see this, you can easily diagnose avulsion of the renal vascular pedicle by CT. And this is another example, and you can see the right kidney is functioning well, while the left kidney does not show any function. In a patient who had received a blunt abdominal trauma, then you highly suspect that the renal vascular pedicle has been avulsed. Then in cases of urinary tract infection, you may have too many conditions, but all of these conditions may present in a triad. And this triad is in the form of the infected or the inflamed kidney is swollen, and the renal function is relatively poor compared to the opposite kidney, with dirty appearance of the perinephric fat due to congestion and inflammation. Then in a case of acute pyelonephritis of the right kidney, you can see these facts. Number one, the kidney is swollen compared to the left side. Number two, the parenchyma is not enhanced, what we call a striated nephrogram. And this nephrogram is homogeneous, but this nephrogram is striated, which is one of the major diagnostic criteria of acute pyelonephritis. Another case of acute pyelonephritis on the right side with a swollen kidney and a striated nephrogram. Parts of the kidney excrete contrast, part does not excrete contrast. And sometimes you got an abscess in the kidney or in the perinephric space, and the abscess is just a well-defined lesion filled with pus with enhancing margin all around. And this is diagnostic of an abscess. In order to differentiate the abscess from the cyst, this is the difference. The abscess has a thick enhancing margin, while the cyst has a very thin non-enhancing margin. And sometimes you can detect air loculi inside the abscess. Here no air loculi, but the difference in the thickness of the wall is very evident compared to these conditions. But if you see gases in the kidney or in the perinephric space, you are able to diagnose emphysematous pyelonephritis, which is a severe or a surgical emergency, usually seen in diabetic patients if you see this appearance of gas. But if you can detect calcium in the kidney, like this one, the dense calcification in the whole parenchyma of the kidney, you suspect the possibility of TB. TB is one of the common causes producing calcification in the kidney. And here you see that the left kidney is very small and it's densely calcified compared to the right kidney, which is good. And this is what we call end-stage nephrectomy or autonephrectomy due to TB of the kidney. Then we came to the miscellaneous conditions, starting by the congenital lesions. And whenever you are suspecting congenital pathology, the best way for evaluation is the IVB. And the IVB, as you know, requires injection of contrast media, and these are the possibilities. Absent or hypoplastic kidney, duplex kidney and ureter, ectopic kidney, horseshoe kidney, pelvic junction obstruction, urethroceles, and vesical diverticulum. These are two different cases of ectopic pelvic kidney. The left kidney is here, adjacent to the renal bladder, and the right kidney is in its normal side. And this is another case of presacral pelvic kidney on the left side, and the right kidney is in its normal location. Horseshoe kidney is one of the frequently seen congenital anomalies in the clinical practice. It can be easily diagnosed by intravenous urography and also by CT scan, as you can see in this image. And this is a case of renal agenesis on the right side. On the left side you see the kidney, the ureter, and the renal bladder. On the right side you cannot see any traces of the renal parenchyma. And the left kidney is showing compensatory hypertrophy secondary to absence of the right kidney. Then the duplication of the pelvic ileal system may be unilateral or bilateral, where you can see here on this left side duplicated pelvic ileal system and duplicated ureter along its whole course until it enters the urinary bladder, with normal appearance of the right collecting system and the ureter. Whenever you see this finding, which is abnormal dilatation or cystic dilatation of the distal part of the ureter, the configuration which is known in our books as the cobra head configuration, this is diagnostic of urethroceles. And this is a congenital anomaly which may be unilateral or bilateral, or may be asymmetric or non-symmetric. Then this is also a common congenital anomaly, which is congenital pelvic-ureteric obstruction. And here you see that the pelvis is markedly distended, and also the calyces are markedly distended, and you don't see the ureter. Then you know that the obstruction is here at the pelvic-ureteric junction, and this is a congenital form which can be unilateral and can be also bilateral. This is the degrees of pelvic-ureteric junction obstruction. This is the normal kidney, and this is a mild form, moderate form, and a severe form, or you got ballooning of the renal pelvis and the calyces as well. And this is an advanced degree of pelvic-ureteric junction obstruction on the right side, as seen by CT urography. This is the left kidney, which is normal. The right kidney, the calyces are distended, and the renal pelvis is ballooned with normal appearance of the ureter. Another case of advanced pelvic-ureteric junction obstruction on the left kidney. The renal pelvis is ballooned and the calyces, but the ureter is normal, and the right side is also normal. And this is an example of vesical diverticulum. This is the urinary bladder connected to the urethra, and this is an outpouching from the posterior wall of the urinary bladder filled with contrast, diagnostic of vesical diverticulum. Then few words about the vesico-ureteric reflux. Normally, whenever the bladder fills with urine, then the patient micturates, and no urine can go back into the kidneys normally. But in cases of vesico-ureteric reflux, the bladder fills with urine. When the patient micturates, urine goes up into the collecting system, may reach the kidney, and then it will drop back into the urinary bladder once more. Then in order to diagnose vesico-ureteric reflux, the best way is the ascending urethrography. We introduce contrast material into the urethra, filling the urinary bladder. Normally, there should not be any contrast material passing into the ureter. But if you see opacification of the ureter, unilateral or bilateral, then you diagnose the possibility of vesico-ureteric reflux. And the reflux has 5 degrees. The minor one, which is a grade 1, is just refluxing into a normal caliber ureter. Grade 2, reflux reaches the kidney with normal appearance of the pelvic ileal system. Then grade 3, the pelvic ileal system and ureter are mildly distended. Grade 4, moderately dilated. Grade 5, severely dilated tortuous ureter with ballooning of the collecting system. Then this is grade 3 vesico-ureteric reflux. This is the urinary bladder. We inject contrast per urethra, and the contrast has ascended into the pelvic ileal system, which is relatively dilated, diagnostic of grade 3 vesico-ureteric reflux. And this is grade 5. This is the urethra, the urinary bladder, contrast passed into the dilated ureter, dilated tortuous ureter with distended pelvic cell system, diagnostic of grade 5 psychoureteric reflux. Ascending ureterography is also valuable in assessment of urethral pathology. And here is a case of urethral stricture, which is a common finding in the clinical practice. You can see that this segment is narrowed with irregular outline, diagnostic of stricture in the anterior urethra. And this patient had a history of trauma to the perineum. And ascending urethrogram showed extravasation of contrast material outside the urethra into the soft tissues of the perineum, diagnostic of post-traumatic urethral rupture. Then finally, we came to the conclusion. We looked to the clinical picture of the patient and we selected the optimal diagnostic procedure. Starting by patients with renal colic, suspected to have urinary calculi. Then we start our evaluation by simple plane and ultrasound. If we can reach a diagnosis, well. If we cannot reach the diagnosis and these techniques are inconclusive, then we go directly to the CT-UT, which is performed without the need of injection of contrast material. By this technique, you can detect the site of the calculus and its size as well, and you can assess if it is associated with back pressure effect or not. Then if you would like to know something about the renal function and you have to inject the contrast material, then you use the intravenous urography as a complementary test. Then in cases with hematuria, the diagnosis is either urinary tract calculi or tumors. Then we start usually also by the plane UT and ultrasound. If we detect the stone, or if we cannot detect the stone, we can proceed by the CT-UT. But if we see a tumor mass, then we should have the contrast enhanced CT scan in order to differentiate between cystic and solid. Then we assess for lymph node pathology and we detect vascular invasion and the metastatic deposits. But if we cannot inject contrast material because of the bad renal function or the hypersensitivity, then we may use MRI. And MRI, as I have said, does not require the injection of contrast material. In traumatic patients, the most optimal technique is contrast enhanced CT scan. No need for plane UT, no need for ultrasound, no need for intravenous urography. Go direct for contrast enhanced CT. Then you will see perinephric hematoma or renal lacerations or renal vascular pedicle avulsion. If you cannot inject the contrast material in the CT scan and you have no choice, you go for MRI and the MRU. And you know that MRU and MRA does not require the injection of contrast material. Then if congenital anomalies are suspected, the optimal way is intravenous urography. And by intravenous urography, you can see all the congenital anomalies, including absent kidney, ectopic kidney, horseshoe, pelviureteric, urethrocoel, and vesical diverticulum. But if you cannot inject the contrast material in intravenous urography, and you have to go for MRI urography. And this MRI urography is exactly similar to IVB, but it does not require the injection of contrast material. And I thank you very much.